Hi everyone, welcome back to Optives. This is Babs, fourth year optometry student, and in this video we are starting with our clinical procedure. So the first one we're going to be looking at is the pupillary reflex test. So let's begin. We're starting off by looking at the anatomy of the iris, the pupillary reflex pathway, the procedures in the test, and how to record your findings. Starting off with the anatomy, the pupil is the opening within the iris, and the iris actually determines the size of the pupil, the shape and the size of the pupil. So the iris is made up of two different fibers which regulate the size of the pupil. There are circular muscle fibers known as the sphincter pupillae and radial muscle fibers known as the dilator pupillae. So here is a picture of the sphincter pupillae. Those are the circular muscle fibers which are responsible for constricting the pupil or making it look smaller. And we have the radial muscle fibers known as the dilator pupillae, which are responsible for making the pupil look larger. Now moving on to the pupillary reflex pathway. There are two pathways, the afferent and the efferent. The afferent sends impulses from the eye to the brain, whilst the efferent sends impulses from the brain to the eye. The afferent pathway begins as the retina is stimulated by light entering the eyes. These signals are then transmitted or relayed to the optic nerve. From the optic nerve, these fibers are then relayed to the optic chiasm. Now, at the optic chiasm, there is crossing over or decussation, where half of the fibers move to the opposite side and half of the fibers remain on the same side for each eye. The ones which move to the opposite side are known as the contralateral fibers, and the ones which remain on the same side are known as the ipsilateral fibers. From there, the fibers then move over to the optic tract. So each optic tract contains both contralateral and ipsilateral fibers. From the optic tract, the radiations are then relayed to the midbrain, and that brings us to the end of the afferent pathway. Not the end of it. So when it comes to the efferent pathway, there's a different pathway for constriction and there's a different pathway for dilation. So we're going to take the constriction pathway first. The pretectal nucleus projects both crossed and uncrossed fibers to the ipsilateral and contralateral Edinger-Westphal nucleus. The Edinger-Westphal nucleus also gives rise to preganglionic fibers, which exits with the cranial nerve 3, the oculomotor nerve. The preganglionic fibers then synapse with the postganglionic fibers at the ciliary ganglion, as seen. Yes, I know that was a lot to take in. So here are the structures, the major structures in each pathway. So for the afferent pathway, the fibers move from the retina to the optic nerve, to the optic chiasm, the optic tract, then to the midbrain. For the efferent pathway, the pretectal nuclei projects internuclear fibers to both the contralateral and ipsilateral Edinger-Westphal nuclei. It then travels along with the cranial nerve 3, the oculomotor nerve, where it synapses with the ciliary ganglion, and from there to the short ciliary nerves, and finally to the dilator muscles. The sympathetic pathway for dilation is a longer one. It begins at the hypothalamus, where the efferent fibers are sent down the spinal cord to synapse at a place known as the ciliospinal center of Budge. Wow. After synapsing at the ciliospinal center of Budge, they exit the spinal cord at a level known as T1. That's the level of the thorax. They then synapse with the postganglionic fibers at the superior cervical ganglion, and this is located around the angle of the jaw. The postganglionic fibers then pass through the internal carotid artery to the cavernous sinus through the superior orbital fissure to join the ophthalmic division of cranial nerve 5, which is the trigeminal nerve. Then finally, they reach the dilator muscle. Wow, that was really long. So here is a brief summary of the major structures. The hypothalamus, the ciliospinal center of Budge, they exit the spinal cord at T1. They go and synapse with the postganglionic fibers at the superior cervical ganglion. Then they go through the ophthalmic division of cranial nerve 5, then to the dilator muscle. That's easy, right? Okay, so why do we have to know all these structures and pathways while we're just going to do the reflex test? Now, the pupillary reflex test helps us to check the integrity of these structures along the pathway. So, if there is a defect, a pupillary defect, there may be a problem with one of the structures along the pathway, either the afferent pathway or the efferent pathway. Now, finally moving on to the pupillary reflex test, we have 3 tests that we mainly do. That's the direct, the consensual, and the swinging light test. Starting with the direct pupillary reflex test, what are we trying to do over here? We're trying to observe the pupil which the light has been placed on. And what do we expect to see? We expect the pupil to constrict as the light is brought towards it. So for the procedure, you have to be in a fairly dim room. You explain the procedure to the patient that, hey, hi, I am going to observe what happens to your eye when light is brought towards it, right? Or how well your eyes respond to light, or your pupils respond to light. Then you ask the patient to look at a distance target. So if there's a VA chart, a distance VA chart there, you can ask the patient to focus on an optotype. You then place the pen torch or the pen light in front of the eye you want to observe, slightly below the visual axis, and you repeat this procedure 2 to 3 times to confirm your findings. You also take into notice the size of the person's pupil, the shape, and how fast it's reacts. Okay, so because of the video, we did not turn off the lights in the room. So here is me with the patient. I am explaining the procedure to her, and then I'm going to ask her to fixate on an optotype on the VA chart. So this is how you perform the direct reflex test. You observe what happens to the eye which the light is on. Now moving on to the consensual reflex test. Now we're going to place the light source on one eye and observe the other eye which doesn't have the light on it. And what do we expect to see? We expect to see the other eye which doesn't have the light on it being constricted. And how does this even occur? Why do we have a consensual reflex? We have it because of the fibers that cross over at the optic chiasm. Remember, some of the fibers from one eye crosses to the other side, and the fibers that also cross over from the pretectal nucleus to the Edinger-Westphal nucleus. I think you need to remember this. It does come in handy sometimes. Now moving on to the consensual reflex. Okay, moving on to the swinging light reflex, we are comparing both the consensual and direct reflexes in the eye. We swing the light source from one eye to the other. We repeat about 3 times, and this is how we do it. When you put on one eye, the light source spends about 2 to 3 seconds on one eye, then it's swung to the other. What do we expect to see? We expect to see the pupils constricted as we swing the light from one source to the other. When the pupil does not constrict adequately, then we can suspect what we call the relative afferent pupillary defect or Marcus gun pupil, and that's an incomplete lesion or a partial lesion along the structures on the afferent pathway. So when there is no light, both eyes are dilated. When we take the light to the eye that is okay and does not have any defect, both of them constrict, right? But when we take the light to the defective eye, that is the eye with the RAPD, it's still dilated. It does not constrict, meaning that there's a lesion along the afferent pathway. Okay, finally, the recording. How do we record what we find? We record this as pillar. The pupils are equal, they are round, they are reactive to both light and accommodation. So we check the pupil size, the shape of the pupil. Are they round? Are they equal in size? Do they react to light as we did in the test? And do they react to accommodation? That is a near target. There are also other conditions that can be detected using the pupillary light test, and we'll be talking about those in other videos, like the Agar-Robertson pupil, the tonic pupil, Horner syndrome, and the amaurotic pupil. Finally, we've come to the end of the video. I hope you learned something. Thank you so much for watching, and see you next time.